Good morning, and respected chairpersons, senior teachers, senior physicians, and dear colleagues. My topic is perioperative antiplatelet management after a recent PCI, or percutaneous coronary intervention. This is a 64-year-old patient underwent PCI for anterior wall STEMI with a newer generation DUS 2 months back. Now, patient has prostate malignancy requiring surgery, and surgeon demands stopping of all blood thinners. So this is a clinical dilemma we all face in day-to-day practice. Here the key is the antiplatelet management. This shows that, there is two groups which is essential in a post-PCI patients. One is the COX-1 inhibitor aspirin and the P2Y12 inhibitors clopidogrel, prasugrel or ticagrelor. Rationale, these antiplatelets reduce thrombus burden and flow obstruction, reduce the pre-procedural damage, especially the side loss and the slow flow, as well as prevent stent thrombosis. But in a later stage, maybe after 2 or 3 months, the antiplatelet agents which the patient will be on will be aspirin plus one of the P2Y12 inhibitors, ticagrelor, clopidogrel, or prasugrel. So suppose we have an elective surgery, elective non-cardiac surgery. It is recommended that in ACS patients, the DUS should be, we can recommend a delay of more than 12 months. But in a chronic coronary syndrome with DUS, 6 months is enough, and BMS you can do an elective surgery after 30 days, and balloon angioplasty we can do it after 14 days. But when there is an urgent or a time-sensitive non-cardiac surgery, even after 3 months of DUS, we can try an elective surgery, because waiting further can impair the prognosis of that surgical case, maybe a malignancy or a lymphoma or a other time-sensitive non-cardiac conditions are detected. When we can use the shorter DAPT, the following trials, Master DAPT, Twilight, TICO, Stop Adapt 2, and Stop Adapt 2 ACS, and global leaders, these all showed that in high bleeding risk cases, or a very high bleeding risk cases, we can reduce the DAPT to 1 to 3 months, especially when we are using newer generation stents. And these trials have shown that 1 to 3 months of DAPT may be adequate in selected patients with similar MACE rates and less bleeding. The Stop Adapt 3, in which prasugrel was used, where there is DAPT was given for 1 month followed by prasugrel, which showed there was increased thrombosis as well as bleeding. So when we are using short DAPT, better to avoid prasugrel. You can use either ticagrelor or clopidogrel. The guideline recommendation, current clinical practice guidelines generally recommend continuation of aspirin monotherapy in perioperative patients after PCI. This recommendation is primarily based on expert opinion and observational studies. And in a primary prevention case, we can stop aspirin, but in a neurosurgical or a spinal surgery case, we have to temporarily interrupt aspirin. But other cases, we can continue aspirin to reduce MACE. This is the POSH2 trial, which showed that in PCI patients, aspirin continuation perioperatively reduced non-fatal MI at 30 days without significant increase in major or life-threatening bleeding. And if it has to be interrupted, we have to interrupt for 3 to 5 days. And P2Y12 inhibitors, clopidogrel, we have to stop for 5 days, and prasugrel 7 days, and ticagrelor for 3 to 5 days, as shown in this figure. And continuing DAPT, aspirin plus P2Y12 inhibitor during surgery increases bleeding risk to moderate to severe bleeding risk. So the continue of DAPT only in patients with a very high thrombotic risk with very low bleeding risk. So this is the AHA recommendation. We can see that in patients with CAD who require time-sensitive NCS within 30 days of PCI with BMS or less than 3 months of PCI with DUS, DAPT should be continued unless the risk of bleeding outweighs the benefit of prevention of stent thrombosis. This is the time course of benefit and risk of antiplatelet therapy, because the initial thrombotic as well as bleeding risk tapers after 3 months of PCA. ESC recommendation also says that if in a STEMI ACS, DAPT for 12 months and 6 months DAPT in a high bleeding risk followed by aspirin alone. We'll see what happens in low hemorrhagic risk and high hemorrhagic risk. In the low hemorrhagic risk procedures, when the thrombotic risk is low, we can give aspirin, discontinue P2 vital inhibitor and go for the surgery. While in the intermediate also we can postpone surgery if possible, but if needed we can continue aspirin and stop P2 vital inhibitor. And high thrombotic risk we can postpone surgery if urgent, continue with aspirin and P2 vital inhibitor perioperatively because bleeding risk is low. When there is intermediate or high bleeding risk, low thrombotic risk, you can continue aspirin. Intermediate risk also, you can give aspirin with discontinuing P2 vital inhibitor. But in high thrombotic and high bleeding risk, you can postpone surgery. But if urgent, continue aspirin, discontinue P2 vital inhibitor and resume within 24 to 48 hours if possible, and consider bridging in selected cases. So, risk assessment to guide antiplatelet therapy among percutaneous coronary intervention. We have to assess the bleeding risk, we have to have the ischemic risk and platelet responsiveness and personalize according to that different categories. A few words about cangrelor. It is an IV direct acting P2 vital inhibitor, blocks ADP induced platelet activation and aggregation. It has an immediate effect and offset as well as onset, and T-half is 3 to 6 minutes. About 3 trials with 25,000 of patients showed there is MACE is reduced by 18% in 48 hours, and there is a slight increase in non-CABG bleed. What is antiplatelet bridging? The temporary perioperative substitution of oral antiplatelet drugs with a short-acting IV agents is called the bridging. We usually use cangrelor or a glycoprotein 2B3 inhibitors. In high-risk cases, when we are planning a surgery less than 1 month of this, this is very useful and reduce stent thrombosis, increase bleeding and increase cost. What about heparin? Most of the surgeons will ask, we'll stop antiplatelets, we will give low molecular weight heparin, which is not useful. Heparin or low molecular weight heparin is not useful to prevent stent thrombosis. This is the bridging procedure. I will not go into it. Here what happens, we stop the antiplatelet and 3 days we can give IV cangrelor infusion, then stop 1 to 6 hours before the surgery we can stop cangrelor and go for surgery, and after the surgery immediately we can start cangrelor infusion, and within 48 hours, 24 to 48 hours we can stop infusion and give the P2Y12 oral agents. This is the switch, and in our patients I will ask the urologist how much is the risk of bleeding, because CA prostate supposed to be a major risk of major bleed is up to 4%, that is 1 in 25 can have a major bleed. So ideally I will stop ticagrelor 5 days prior, continue aspirin, discuss with the surgeon, patients and relatives all the cons and pros, and I will do bridging with cangrelor infusion for 3 days, stop 1 to 6 hours prior surgery and restart after surgery, and low ticagrelor 24 to 48 hours after surgery while cangrelor infusion is on. So key takeaways: antiplatelet therapy is essential after PCI to prevent stent thrombosis and ischemic events. The highest thrombotic risk occurs within the first 6 to 12 weeks. Elective surgery should be delayed whenever possible. In DES recipients, delay elective non-cardiac surgery, ideally 3 to 6 months. In BMS, by 1 month. Aspirin should be generally continued perioperatively. If aspirin must be interrupted, stop 3 to 7 days depending on the procedure, and continue DAPT only in patients with a high thrombotic risk or when surgical risk is minimal, and continue DAPT increases moderate to severe bleeding risk. Thank you.
Thank you, Dr. Manikandan. Explained very well about the antiplatelet agent after PCI, when do the surgery, and dual antiplatelet therapy, perioperative continuation of dual antiplatelet, and IV P2Y12 inhibitor.
It all depends upon what is the risk of bleeding involved with the surgery and where you are doing the surgery. There are certain surgeries where we have to mandatorily stop. The intracranial eye, that is the posterior compartment of the eye, and the spinal surgeries. Rest, I think it's a discussion between the surgeon and the cardiologist, whether it has to be stopped completely, or we can go, as you said, and many of the surgeons are now courageous enough to do the surgery with aspirin on board. But whether aspirin really prevents a stent thrombosis, we are not sure. So is it basically to prevent an ischemic risk or a stent thrombosis, the antiplatelet agents?
It is to prevent MACE, which includes stent thrombosis also.
But we are afraid of stent thrombosis, especially in the immediate vicinity of angioplasty, the first 1 month, and whether it is for ACS or non-ACS. If it is for a non-ACS, after a month, it can be relatively safe if you can restart the drugs quite quick. But if it for ACS in the first 3 months, and also what type of stenting, is it only a simple stent for a diagonal, a small vessel, or a bifurcation complex stenting for a left vein, where we cannot afford a stent thrombosis which can be life-threatening. So it depends upon a lot of factors. A blanket statement may not be applicable to everybody.
So the complexity of the procedure, as you said, also has to be considered, whether we are using a very long stent bifurcation left main, where a stent thrombosis is going to be catastrophic.
Sir, should we load the antiplatelet again when we are restarting the antiplatelet agents after surgery?
After surgery, if it is within 1 month, the loading is needed. Otherwise, you can start with maintenance dose. That is what is given.
A loading is, by and large, a loading is required, isn't it? Especially in the early period, the post-stenting period. In neurosurgery and ophthalmic surgery, I think we have to stop the clopidogrel 7 days. That's the new recommendation. Rather than 5 days, they would prefer to stop the drug 7 days prior to the surgery. And do you really need to stop the drugs for the common surgical procedures, minor bleeding risk, cataract, dental, IND?
Most of the surgeons now, ophthalmic surgeons do with all the drugs. Even at least we can stop clopidogrel for a while, but I think ophthalmologists are ready to do cataract surgery without stopping antiplatelets.
Thank you, Dr. Manikandan. Excellent talk and practically so important. We'll give him a big hand.